don't practice, relieving stress when they're pregnant. And we at Healthy Start, we do a risk assessment, and that risk assessment leads to what levels of stress this mom is having, and then we go about trying to eliminate those stressors for mom while she's pregnant, and also to the support system as well. Next slide.
So, shifting now to indicators that are specifically and directly related to maternal and child health, we start with the share of women giving birth who received adequate prenatal care, which is defined as beginning care during the first trimester and having at least 10 prenatal care visits. Um, Prenatal care is considered a key contributor to birth outcomes. We find that there are not major differences by race and ethnicity in Oklahoma, but at 49%, African American women are a bit less likely um, to receive adequate prenatal care than women of other races. About 61% of white women receive adequate prenatal care in Oklahoma for an inequality score of 73.
This is an area I like to brag on because that is kind of what Healthy Start is about, getting mom into early prenatal care. But let me say that in the past, what I've seen is that sometimes moms will not get into prenatal care until the end of their second trimester or their third trimester. They, like I said, don't get messages that we send out or messages that are sent out to relieve stressors while they're pregnant as well. Um, we also have seen that some moms just pretty much have to meet their basic needs, and adequate prenatal care is not important to them. And that's why you see a lot of moms drop on the emergency room doors because of the fact that it's just really not important to them that they're having a baby. And when they go to the doctor, they get kind of used to the doctor just taking their way, getting them some information, and also kind of like sending them on their way with the information. And of course, what we see sometimes is that mom, outer support system doesn't support her in returning back. So they get into missing their prenatal appointments as well. So next
Next
slide.
slide. So, preterm births are live births occurring prior to 37 weeks gestation. This is one of the primary direct causes of infant death. Preterm birth increases the likelihood of developmental delays and other long term health problems. African American women in Oklahoma are almost twice as likely to deliver a baby preterm as are Asian women at a rate of 15.3% and 8.7% respectively for a score of 50.
And this, I'm going to go from a culture perspective. Sometimes people really underestimate why someone has a preterm birth. And in the African American community, women are taught to be strong. And so most of the stressors do, may not look like stressors to us. And so what we normally do is we normally go on our merry way without without maybe stop smoking or overeating or trying to find information about proper nutrition during your pregnancy. And so, like I said, stress leads to a lot of preterm births, and we see that a lot in well, don't see it a lot. I would say we do see it in Healthy Start. But as it relates to my culture, I do see it a lot in African American women. Next slide.
Low and very low weight births are defined as babies weighing less than 5 pounds 8 ounces and 3 pounds 4 ounces, respectively, at birth. Preterm birth is one of the most common causes of low birth weight. African American women are about twice as likely as women of any other race in Oklahoma to deliver low or very low weight babies for a score of 40.
And that just goes back to what I'm saying, what I said about stressors and just, knowing how to take care of your body plus baby when you're pregnant. And we see a lot of African Americans not doing that. Also, it could be moderations in what you're eating. And there may be high levels of sodium, high levels of just anything that may, also affect their pregnancy. So, next slide.
Slide.
So this is just, of course, if you're familiar with Healthy Start, our mission is to reduce infant mortality. And as you can see, our numbers in African American community is still high. I would like to say that HRSA finally recognized that and started to shift the way that we do business just a little bit differently. So we get to focus now more, not leaving other races out, but focus more on African Americans. And like I said, the last year we knew that needle point was moving towards doing more concentration. In this cycle of a 5-year cycle, I'm seeing it more. There's other ethnicities there that you can see that have infant mortality rates, uh, but African American is extremely high compared to the other ethnicities.
Um, Good points, Karina. And when you compare the rate for African Americans to white women, you see that we get an equality score of 38 because African American women are 2.5 times as likely to experience the loss of an infant as are white women in Oklahoma. And what research finds is that even when socioeconomic, health, and prenatal care factors are held constant, African American women in the US in general continue to experience greater levels of infant mortality than women of other races. A growing body of research links this persistently higher rate to maternal stress levels, as Karina has talked about in prior slides, specifically stress related to racism, individual and personal racism, continuing structural and systemic racism, as well as historical racism, effects of which can be inherited. And we'll talk more about that when we talk about risk factors and root causes. And next slide, please. So maternal mortality is the death of a woman while pregnant or within 42 days of the end of pregnancy from any cause related to or aggravated by the pregnancy or its management. African American women are at least twice as likely to die due to pregnancy or pregnancy management as are women of any other race, but they are 12 times as likely as Hispanic Latinx women to do so. This produces an equality score of 1, the lowest score possible in equality indicators.
Yeah, and let me just touch bases on this right here. I have to give kudos to CSC for doing some early studies on maternal mortality. But what we're seeing is that women are they're not healthy, and they're not healthy before they get pregnant. And sometimes the system is working against them, not for them, such as doctors not listening, such as whoever is creating what system, your African American women and any other ethnicity, color women, um, is who I'm speaking of, and that could be the Hispanic race, Asian. Don't have a lot of input and say into the system that is being built for them, and so you see a lot of them falling through the cracks. And we're starting to see a lot of moms after they give birth, as you know, we've pretty much mentioned that as they give birth or whatever, their support system is not there for them, and so you see a lot of them depressed, and depression is huge in maternal mortality as well. So
I have a question on this, a
yeah.
couple questions. So this particular slide on deaths per million, this is Oklahoma specific data, correct?
And you know what? I'm sorry. That should say 100,000. That's a typo. I'm glad you pointed.
Oh, okay. Okay. I was
I didn't even see it either, Kim.
okay. Well, no, okay. So that was what was throwing me. I was like, is this national or state? Okay, anyway, sorry, that was one.
Yeah.
And then I thought the Native American and African American maternal mortality rates were actually more comparable. And I thought Native American maternal mortality rates were higher than white maternal mortality rates. Is this data different than prior years? Are Native American deaths going down, or is it that the numbers are just so low that one death can cause that level of change between the white and Native American numbers within a given year?
That is a great question. And I will say these data points come from, as noted here, from the Maternal Mortality Review Committee. And I believe this is for actually a 9-year time span from 2010 to 2018.
Okay.
Sorry, as I look off screen a little bit, I'm looking at the actual data source. And it looks like American Indian has been, through part of that time span, higher than the other races, but still not that close to the African American rates. The Maternal Mortality Review Committee has released in November, I believe, their 2020 report. So if that's something you're interested in, you can find that.
Okay.
So
one other question on this too, though, on the Maternal Mortality Review Committee data. So is it the case, because I know they're way behind on the cases that they're reviewing, like I was talking to someone who's on it, and they're like 2 years behind on their reviews right now, and they're doing like 4 reports like per time that they meet. They only meet like a couple times a year. Anyway, is this based on the cases they've reviewed, or is this like the hard and fast deaths per year in Oklahoma? I'm just wondering that, because that could be different.
That is a great question, Kimberly, and I'm afraid I don't have enough information to be able to answer that question.
Okay, thank you.
I think it addresses that in the report, and I just can't. I don't want to misspeak and say the incorrect thing. I will say I already did give you some incorrect information, that those numbers are not 2010 to 2018, but 2016 to 18. But when you look at the longer time span going back to 2010, during that whole time, the Native American rate is considerably lower than the African American rate, except very early on in that time period when all of the rates were very close together. So
I had one additional question on here. Is this combined? Because I know that the Tulsa County community and the Oklahoma City have 2 different maternal mortality review boards.
this is
on the one from city.
my understanding is this is the Oklahoma, yes, Maternal Mortality Review Committee. So
I think there's only one review board though for the whole state. I think there's 2.
No,
mortality.
there's 2. I'm sorry. I didn't mean to cut you off. There's 2,
No,
and the
really?
numbers don't.
Huh.
okay,
Yeah, there's 2 because we have Oklahoma City, and they do 5 counties, and Tulsa, I'm not sure how many counties they do, but they're different. I serve on one of the infant mortality review boards, and they are not combined. However, I was asking because I'm noticing it says Oklahoma. It didn't say Oklahoma County. So I'm curious as this is combined from the 2 programs.
Yeah, this is the entire state of Oklahoma.
Okay, thank you.
Sure. And these are great questions for clarification. And I apologize, I can't give better answers to some of these, but and I also be glad to make this report available to send this report to TCI, and they could make it available to attendees.
Sorry.
I'm not a part of that committee, so that's why I can't speak too well of it. But obviously, some of you on the call have much more information. about this particular indicator.
There's one more question. Do you mean infant or maternal?
This is talking about maternal mortality specifically. The prior slide was infant mortality. So
No,
this is,
yeah, I got that. I'm just confused on, I just was under the impression that there are infant mortality groups in Oklahoma City and Tulsa as well as a state one. But last year when they were redoing or 2 years ago, sorry, time runs together now with the pandemic, but
right.
with the MMRC legislation, they were people wanted to have city level ones, and they said there wasn't enough data to do city ones. So that's where I was confused, because I'd heard we couldn't have them.
Mm-hmm.
Anyway, I don't know.
So yeah, and again, I apologize for the typo on that slide. And I when I was doing it, I was careful thinking 100,000. So somehow that got past me, but that should be per 100,000 births. So that again is for a 3-year time period. So you know, they would be relatively smallish numbers to look at by city for a smaller time period, but yeah. Any other thoughts about this topic?
No, but what I wanted to say is that most deaths that I do see, and of course we always look at the ones that's after delivery, but those women, like I said, was not healthy. Most of the African American, the number one was, you know, heart disease and obesity being, you know, the two leading ones, and then hypertension as well. So those are some of the things that we didn't, you know, that we looked at after uh, delivery and as they go into interconception.
Next slide, please. So those 11 indicators are the ones we looked at for this particular analysis of data by using equality indicators as a framework. And what we come up with overall is a score of 44.2 out of 100 for Oklahoma women's health. So that's not good. I mean, if you were to put that into a grading system, that would be failing, very poor failing. So, and again, this is reflecting the disparity between different groups on these health measures. This is again not saying we get a 44.2 on overall Oklahoma women's health. It's talking specifically about the disparity among different population groups in the area, specifically of maternal and child health.
And I want to say, as it relates to Healthy Start, that our numbers, where we do a great job of serving our consumers, we're still seeing that Oklahoma is one of the worst in prenatal care and perinatal. So that's kind of bad. It's like a double defeat, but that's what it is.
And next slide, please. So we want to talk now about risk factors, root causes, and solutions. We're going to dig both into individual and systemic risk factors that directly contribute to these disparities, as well as root causes that underlie these and many other disparities and drive these and many other disparities experienced by population groups in Oklahoma. Then we'll shift to potential solutions. And it has been great discussion talking about the data. And if you know me, you know I love talking about data and what the results mean. But I just, I want us to really have time to look at risk factors and root causes and solutions as well. So next slide, please.
I also just want to give you a time check. We have about 20 minutes left.
Okay. And that's 20 minutes, not allowing time for questions. So we'll try to keep, we'll try to talk fast.
Yeah. So these are some of the actual risk factors with the Healthy Start. When we wrote the grant, those were some of the very stressful risk factors of Healthy Start is the reason why you see them listed here. And the main ones, which is tobacco and substance abuse and domestic violence, were huge. And of course, that just rolls right along with distress and depression. And so, what we saw, and like I said, I've been with Healthy Start for 23 years, but what we saw then is still uh, pretty present today with our clients.
Next
Next
slide, please.
slide. So you come to the somatic, thank you, risk factors. I almost didn't get that out. And we look at some of the things that I've talked about earlier, but some of the things that we don't see is why these moms are not getting into prenatal care early. Some of them, like I said, don't get in until the third trimester. And these are just some of the things that we've listed, such as past medical bills. We've gotten a lot of not wanting to go back to the clinic or not wanting to go back to that particular clinic because of past due bills. There's moms and just their support systems that don't have the money to uh, to pay to go to prenatal care, prenatal costs. I do know with some of the Medicaid, they do have, it all depends. Well, not Medicaid, I would say SSI. They do have a co-payment attached to their benefits. When they go to the doctor, they need to pay a copay out of their benefits. Food deserts, not having enough produce, not having grocery stores in different places. And we've all heard that before, of where those areas are where we can point out where the food deserts are. Transportation barriers. I was telling Melanie the other day, I said, 23 years of this. And of course, I also directed the demonstration program, which was through WK Kellogg. And we're still seeing transportation barriers to care. And it's just surprising, but it's still there. And then just, negative police contact. You've heard it in the news today, what they're going through, and it still happens that they're still going through it. And it's a shame, but it's the truth. But it has a negative effect on um, the, the, the care that they seek out. Uh, they may not go to the doctor because they don't want confrontation or somebody's, recognize their name, through the blogs or whatever. So we see a lot of that. Next slide. And your root causes, Healthy Start, we see a lot of where we deal with trust issues. We deal with um, their history, their culture. I know in the African American community, our culture, I was sharing with Melanie earlier, is that I remember having an ear infection, and my mom, she just kept putting sweet oil down my ear instead of taking me to the emergency room. And I think she did that about 3 months or so, and it just kept getting worse. And she finally had to take me to the emergency room. They were like, why didn't you bring her early? She has a severe ear infection, and now, we've got to water pick her ear and everything. But I just knew how my mother felt at that particular time, and I can just imagine what other people go through when they go to the doctor. But a lot of it, like I said, we try to fix it ourselves, and sometimes that's not good. But and then racism plays a huge part in African Americans seeking out care because you see it so many times, and from those very same people that say that they don't do it, that they don't believe in it, and you'd be surprised at how much they're in the system and making decisions for these women. So um, those are just some of the root causes that we see in Healthy Start.
And another, before we move to the next slide, racism from the perspective of what it does to the body, and I'm including both present racism personally experienced, and also historical racism that is passed through intergenerationally, and the weathering that causes to one's body, just specifically from the stress from that experience. So we cannot ignore that that is real and has an impact on health outcomes. And next slide, please.
Let me add to that confidentiality too. We see that a lot, and I said trust, but I think if I put out confidentiality too, that's a part of the trust issue we see a lot of.
So we borrowed this maze of life diagram from the perinatal quality improvement PQI with permission, but we find it a really helpful depiction of the systemic risk factors and root causes that we've just been talking about by laying out the different paths that women face in their healthcare journey. So PQI created this maze of life image to help illustrate the fact that the starting point and the path for African-American pregnant women is a more difficult path, more twists and turns and more obstacles than the path that most white pregnant women embark on in order to achieve health and prosperity. The African-American woman is weighed down from the start with a heavy burden symbolized by the backpack that reads 246 years of slavery and also fear of dying. And I wanted to throw in here, I just saw or reminded of a James Baldwin quote: "History is not the past, it is the present. We carry our history with us. We are our history." It's crucial that we look at things that have happened in the past in Oklahoma. But at the start of the African Americans woman's path are Jim Crow laws, racist policies, unequal human rights, legalized rape, disproportionate incarceration, and in the context of lynching of loved ones and the fear of lynching, which then lead into families being separated, high rates of infant mortality, redlining, breastfeeding white babies, police violence, disparities in educational resources, unsafe water, limited access to quality health care, and other dead ends that all make it more likely that a Black woman will experience morbidity and mortality and infant mortality when giving birth in the United States. That Black women can achieve health and prosperity, but the path to health and prosperity is much longer and more difficult to navigate. This maze also shows that a white woman can experience maternal morbidity and mortality and infant loss, but it is less likely that she will experience those. We can't change the past, but we can learn from the past and be aware of how the past is affecting us today and eliminate and dismantle all racial disparities by dismantling racism. And next slide, please.
And here, I guess I'm kind of biased here. Melanie was biased too, but all three of those are my grandbabies. So, yeah, Shamar standing by the Corvette there, and then Butter Muffins, who's eating a cracker cookie, and also the bottom one is Shanice, and Shanice is the newest to the crew. So she's born June the 3rd. And so anyway, but what I would like to say is that our healthcare system, we do have some great potential um, systems in place, such as Healthy Start. And we make sure that we link those women up to providers that can take care of them during their pregnancy. We rely on our partners to help us out, which is also OSU. And also Utica Park and St. John's. So we all are working together to make sure that we provide the best prenatal care that a woman can get when she's pregnant, and also work with her system as well, but eliminating barriers to care. And we are still trying to do better in that area, which is transportation is one big one. But then with eliminating barriers to care, it just goes back to Maslow's hierarchy. Sometimes health is not important to them. So, like I said, we depend on our partners to help us do that, and we also do a lot of building a trust with our clients to make sure that they can get into the best care possible, and anything that they want to ask us, we are there for them. And I think that's the difference with Healthy Start is we building that bond and building that trust. We're able to get what we need from them, and they're able to get what they need from us.
Next slide, please.
And so when I talk about potential solutions, there's Brandy, who is very, very important to our program. She works for Healthy Women, Healthy Future. They do our interconception piece. She is our behavioral health person, and Melanie talked about that earlier about importance. It's so important for them to be in the best uh, behavioral trust place. That's not the word I'm looking for. I just went blank with it, but so Brandy does an excellent job. We also have Bethany, who does an excellent job with hooking ladies into prenatal care. We have a wonderful coordinator that works along with also the wonderful care coordinators to make sure that we get the whole family into some type of care. And when I say that, we also have a fatherhood program that works with the significant other of the father of the child that's being born. So we have a lot of things that we do. We do a lot of listening to our clients and putting things in place. We are client driven, and we like to brag about that because they are. When I say they are, consumers are important to developing and our structure of our program, and we couldn't really do it without them. We need that feedback to make sure that we're doing the best that we can for them. Some sometimes they don't have the living wages to pay for a doctor or so. And what I like about Healthy Start is that it would, our powers that be went back about 7 or 8 years ago, and they lifted where somebody had to be able to pretty much enroll in, qualify for enrollment in Healthy Start. And so now they don't have to do that. It serves everyone, and I'm glad to see that happen because it too helps us to erase infant mortality in certain census tracts and certain zip code areas. So glad to be a part of Healthy Start. I'm glad Healthy Women, Healthy Future is a part of us. I'm glad that Melanie is a part who is also our data management for Healthy Start. And the rest of the crew, they know who they are. They pretty much make up a awesome team. And like I said, we received great feedback on that. So as part of the solution, Healthy Start, Community Service Council, part of the solution. I'm glad I'm a part of both.
And next slide.
Mel.
Yeah.
Go, Mel.
Okay. So I'm going to real quickly, we're about to wrap it up and hopefully get to a couple of questions, but everybody has seen the comparisons of equality and equity. In fact, I'm just going to go to this one that compares both of them. You see in the top picture, which they're calling equality, compared to the bottom picture, which they call equity. This is also from the perinatal quality improvement. Again, PQI, and I have the website there if you're interested in looking in that. This is the best depiction of the comparison of equality and equity I think I have ever seen. But the top one, of course, showing that each woman is given an equal box, an equal set of resources, basically. But you can see only whatever the women can really can reach the fruit of the tree. The difference in these women, they have the basically the same body structure, the same height, the same abilities. But notice the thing I really like about this is the foundation that they're standing on is what varies. So the foundation that supports them, you know, and I like to consider that part of their history and our culture and individual groups' cultures and the systems that we have set up in our society that are inequitable for different population groups. That's basically what is forming the foundation that these women are standing on. So in the second one, which is showing equity, it shows you don't necessarily give the exact same resources to every person or every group of population because they don't need the same resources. You give them the resources they need based specifically on those needs and those conditions that they are standing on and that are supporting the structures that we have put into place that put different groups of people kind of in different situations. So
And
just
can
kind
you
of
say,
wrapping. What's that?
Melanie, also too, as it relates to a healthy start in my culture or whatever, it's so important that those individuals that you're serving, that you give them a voice in what it is that they're needing, because just like Melanie stated earlier, you know, some some cultures, some ethnicities may need more than others. Some women may need more than others, but we have to make sure that we're in the listening mode where we can get them what they need to in order for us to build a healthy infrastructure for these women.
Absolutely. So I think we're ready for maybe hopefully a couple of additional questions and answers. If anybody has questions